informatics. In today's talk, I'll be discussing with you about trauma-related and neutral force memories and associated biological markers and intergenerational effects in PTSD patients following exposure to 1994 genocide against the Tutsi in Rwanda. This project is being implemented at the University of Rwanda in collaboration with Radboud University, University of South Florida, and Vrije University of Brussels. Forced memory is defined as a phenomenon where people recall things that were not presented to them or record it differently from the way it happened. This Rodriguez-Delmont paradigm is one of the paradigms which is used in measuring the forced memories, and this paradigm sees these forced memories as source monitoring errors, which are produced when there is a presentation of series of words which are semantically related to the real world, and then they conjure up in mind of a participant. According to the scientists, first memories are part of the working memory and can be triggered from anxiety and stress. PTSD is considered as a disorder that also affects memory because people with that condition, they are troubled by recurrent intrusive distressive memories of traumatic events. Science has shown that there's an impact of associative activation mechanisms in the linkage between psychopathology and forced memories. And mostly the forced memories are produced when there is associative material which has been presented. So according to the researchers demonstrated that there is a link between war-induced PTSD and disorder. And also these dissociative symptoms are positively correlated with susceptibility to forced memories on DRM task. PTSD group forcefully recognized more critical role than other trauma-exposed participants with DRM task, according to the different scientists, but these discussions are under debate. Other scientists report that PTSD patients recall fewer words than participants without PTSD. Although several studies have been exploring the linkage between trauma-induced PTSD, there are many discrepancies between the findings on correct recalls of word and trauma-related cognitive tasks from DRM task. And there is no study which has been implemented in the context of Rwandan genocide with transgenerational effects on maternal stress. On the other side, at biological level, there are different biomarkers which have been reported to contribute in cellular stress response, such as HSP70, HSP90, and HSP27, cortisol, and others like glucocorticoid receptors. These biological markers have been reported really to be important in cell survivors, and so we hope to study these biomarkers in our ongoing studies in the Rwandan genocide survivors population to understand the level of expression of these proteins in non-traumatized population and also traumatized population. So our hypothesis is that PTSD patients may have a particular impairment in source monitoring and towards tendency of higher production of forced memories on DRM list in the context of genocide exposure. There are other different hypotheses being tested in this project, like as mentioned, level of expression of mineralocorticoids and the mentioned proteins, as well as glucocorticoid receptors. We assume that they differ between non-traumatized population versus traumatized exposed population and their offspring. We are also testing if there's a correlation between level of corticosteroid receptors and examined heat shock proteins, and this correlation may differ between the exposed group versus non-exposed group. We also want to test if there's association between DNA methylation and memory impairment, as well as intergenerational effects of PTSD and trauma among Rwandan genocide survivors. So our motivation here is that according to the global statistics, 70% of mental disorders contribute to global disability adjusted life years, which brings to the high level for burden of PTSD, like it is ranging at 3 to 4%, and depression at 4%. But when you look on the right side of this presentation, for Rwanda, the burden of PTSD is high among genocide survivors. It's at 28%, and depression is at 10%. So this really is motivating us to study more, to have more research questions in this population, so that we can build interventions to alleviate the burden in Rwandan population. So with this DRM paradigm, we want to use it in Rwandan context, and this may maybe decrease the discrepancies which are in available data on susceptibility to recall, critical rules, and trauma-related cognitive tasks. So the objectives is to examine the free recall and forced memory rate among Rwandan genocide survivors, and to determine the association between trauma exposure and memory impairment. So as I mentioned, this is a piece of work which is linked with the ongoing project under NIH grant support and H3 Africa, which is looking at epigenetics and intergenerational effects in maternal stress, where we are determining DNA methylation status following exposure to 1994 genocide against the Tutsi, and also try to illustrate the intergenerational effects and epigenomic changes associated with PTSD and genocide. Methodology of this part, we are using DRM test, as I mentioned, and the DRM test is applied with the presentation of list of words that are associated with trauma, with also non-studied critical rules. The stimuli is 20 list of random words. Each list contains 10 words associated with one non-presented word. The 20 lists are divided in two sets, trauma-related words and neutrals. So the study design, it contains case and control groups. We will be having 150 PTSD cases, 150 resilient, and also 150 control group. Those who were not exposed to genocide, who were outside of Rwanda, women and their children during 1994. As I mentioned, the study tool is this Rodiga MC Dermot effect, and we generated our own trauma-related words and neutral words based on DRM lists which are available. So in our pilot phase, we did it on 36 participants, and we wanted to test the internal validity of the tools to be used. And these participants were students and staff members at the University of Rwanda. And then we added women and men at Kibagabaga Hospital who were chosen randomly. And this pilot has taken between 27 to 58 minutes. We did also pilot phase 2 to make sure that to test free recall and free recognition on generated lists. And this pilot was implemented at the same site, Kibagabaga Hospital in Bugesera, and a total of 50 participants were tested in 3 days. All participants were at Aheza Healing Center, and the time to complete the task were between 40 to 60 minutes per participant. So some of the findings that we've seen, we've seen that the list of words which were presented to the participants behaved to not be remembered easily and were not really associated between them. So here we are thinking that maybe culture and language are suspected to play a major role in DRM tasks within Rwandan context, but this needs to be confirmed at the larger population. The same with pilot 2, where we wanted to test the free recall and forced memory rate. We found that the free recall and forced memory rate was very low for all 20 lists which were tested. Only 2 words were forcibly recalled. And so it shows that the free recall was very low, and also the recognition was not well taken. on the average of these lists recalled, 4 words were remembered per list. So these are the findings of the pilot, and we are revising now the tools according to the findings from the pilot to really increase the validity of the tools that is going to be used on the larger population. So the next step is that we want to revise the tool by taking into consideration of those cultural and linguistic factors. And also we anticipate to organize community engagement on memory quality study. And then we do data collection for the entire population for the 450 sample sets that we are anticipating to have by September to December 2021. So I acknowledge support for my supervisors, Professor Dion Mutesa, and Dr. Stefan from University of Rwanda, Professor Monica and Professor Derek from University of South Florida, Professor Beno and Professor Elno from Radboud University, and Professor Rose Gemini from VH University Brussels. Of course, we appreciate support from NIH and H3 Africa to be able to implement this kind of project. I thank you very much for your attention.